very much for the introduction, and I want to start by thanking the organizers, in particular Dr. Sana, for the invitation and for nutritionals who supported this presentation. I've been invited to talk about the nutritional management and growth faltering in infants. It's a topic that I feel extremely passionate about, and I enjoy talking and sharing my knowledge. So if I want to start just with some disclosures, which primarily include some of the academic lectures like this. So what are we going to cover today? What are the objectives? I think whilst all of us know why we want to promote catch-up growth, it's sometimes quite nice just to reinforce that message. We're going to talk about the nutritional goals and nutritional management in faltering growth, energy, protein requirements, vitamin and mineral requirements, practical advice for breastfeeding babies, practical advice for formula-fed babies, what to avoid in the management of faltering growth. Now, most importantly, whilst I'm going to go through the academics of all of this, I'm going to do this on the hand of two cases to make the scientific evidence that we've got much more alive and applicable to all of you listening. Many of you know this graph that was published first in 2013 by a colleague of mine, Nilesh Mehta, who talked about illness and non-illness related malnutrition. Now, of course, we use the word malnutrition, but malnutrition is a growth faltering of more than 2 to 3 standard deviation or Z-scores for weight for height, height for age, where faltering growth is the dropping down of weight generally over 2 centiles. But I like using this graph because it gives you a nice overview of what we can see when we're thinking about faltering growth. On the one hand, we've got non-illness related, which can be socioeconomic, it can be environmental. You have your confounding factor of infection, for example. Then we move into starvation, which can be acute or chronic, and your well-known sequelae that follow after that. Then we have the illness related, which many of us deal with in a hospital setting, which can be your cardiac diseases, infections, cancer, trauma, critical illness. And that, on top of that, you have your confounding factors of infection or inflammation, your increased losses, your energy expenditure that increases, your altered nutrient utilization, your reduced appetite, and then again, your sequelae that follow after that. I think all of us, when we're thinking about our illness-related faltering growth, we can really divide children into these categories of increased losses, energy expenditure increases, altering nutrient utilization, and it's either a combination or one of those. What this graph does not capture, and I think that's really important, is this interplay between illness and non-illness related malnutrition, and that you can have a child migrating from the one to the other. Let me give you an example. For example, you could have a child that had severe gastroesophageal reflux disease, which is now by the age of 1 resolved. And as a result of that, though, this child is not feeding well. So there's no reflux left, but there's such a bad association with feeding, this child is now not wanting to feed. So where it started as an illness related, it's now moved to non-illness related, where you have a child with feeding difficulties. I'm sure you can also think of children with cardiac diseases who have an underlying cardiac disease. Surgery occurred, but after that, as part of the sequelae following the cardiac surgery, they now have feeding difficulties. So we also need to be thinking about how do illnesses kind of feed into non-illness related faltering growth and this interplay between the two. On top of this, and it would be wrong of me for not talking about it, we have the pandemic. And this is just one paper. If you look at it now, there's several papers like this, looking at the possible impact of COVID on the prevalence of wasting, which it's hypothesized could increase by 10 to 50% of malnutrition. That's between 40,000 and 2 million child deaths on top of this globally. And we can all identify how this has impacted in all domains, from reduced income, limited resources as a result of the lockdown, as a result of that, reduced access to food. A lot of us have had to run our clinics from home. We've also seen limited clinic access, that's face-to-face access. For example, me, I'm running for the first time in November, face-to-face clinics. And I know many families have been saying that they've just not been able to get access. And as a result of that, we've had poor dietary intake, higher disease incidence with longer duration, just because health access has been poor, higher risk of integrational transfer, and we see stunting, wasting, underweight, all of those as a result of the pandemic. In the UK alone, we've seen an increase above 10% of food insecurity, which for us is a huge increase. So we are seeing this impact dramatically also on poor nutrition in our country. Why do we want to promote catch-up? All of you know this graph really well, is that within the first 2 years of life, you do the majority or 50% of your height growth. So it's really seen as a window of opportunity for catch-up. You have a second catch-up period, you know, around adolescence. So whilst the vast majority is done below 2 years of age, you still have a window there. And we also know that cognitive development and also brain development occurs not only at the end of your gestational period, but also within the first 2 years of life. So it's really a critical period for us to want to try to promote catch-up growth. I'm not going to go and focus hugely on the short-term and long-term impact. All of you know the short-term impact, you know, from wound healing to longer hospital stay. But also what we need to think about is the cognitive achievements. And the cognitive achievement have a direct impact on reduced income, reduced physical development. And of course, we are now also concerned about overweight and obesity, with the data that shows if catch-up is too fast, and also if catch-up occurs too fast after the age of 2, that is from Andrew Barker's data showing that after 2 years, higher BMI, and also before 2 years, lower weight for age and lower BMIs associated for syndrome X in adulthood. So those are all long-term implications that we'd like to avoid. What are our overarching nutritional goals? And that does not matter in which domain you really work. We first of all want to think about the individual. Whilst I'll be sharing guidelines with you today, we want to think about that individual, thinking about the etiology, because the etiology can be unique to that child, whether that is trauma, whether that is head injury, whether that's gastrointestinal disease. There's a pathophysiology that is quite unique that you need to take into account. Then we want to optimize medical treatment if this is illness driven. And that's why it's so important for us as dietitians to work with our medical team and to call in also where needed, you know, speech and language therapists for oral motor skills, and also any other medical domains, gastroenterology, neurodevelopmental specialists, to make sure that the medical treatment is optimal. For me as a dietitian, I can stand on my head if a child continues, for example, to have excessive losses, continues to have pain when eating. We cannot continue forcing a child to have that. Needs to be resolved first. Then we need to ensure optimal nutritional assessment, the ABCD, so the anthropometrical assessment, the biochemical assessment where appropriate, the dietary intake assessment, and also your clinical assessment is absolutely critical for you to develop your treatment plan. The next step of this course is setting your nutritional aims to achieve catch-up for ideal lean and fat mass, and I'll talk about that a little bit more in detail. Think about your energy, protein, and then of course think about your micronutrients. More importantly is not only about the micronutrients you need for catch-up, but think about correcting for the deficiencies. There might be, for example, a zinc deficiency, an iron deficiency. Those are critical cofactors for catch-up growth. And then we also need to think about oral motor skills. It's not only about achieving energy and protein orally, or if in the severe cases via nasogastric tube feeding, it's about also managing the oral motor skills and not leading to feeding difficulties as you progress through catch-up growth. Then avoiding psychological sequelae as a result of dietary treatment. And I bring this up, a lot of our treatment puts so much pressure on parents to, when we talk about how important it is for a child to catch up growth, parents feel that pressure. This can often lead to pressure on feeding that can lead to a feeding difficulty. Again, think about this interplay between illness-driven to non-illness driven faltering growth. And then, of course, monitor and monitor and monitor whatever we need to ensure that catch-up growth we need to monitor. So I'm going to start off with a case. This is a non-illness related faltering growth. So a boy was born at 39 weeks plus 4 days at 3.5 kilograms, good weight. So that is just above 0 in terms of your Z scores. No antenatal history of note, no medical history of note in early infancy. He was exclusively breastfed until 4 months and then developed RSV bronchiolitis, for which he was hospitalized. He received oxygen via the nasal prongs. NG tube was placed as he would not feed orally, had an NG tube for about 10 days. A mom could not express enough breast milk, so he was breastfed until there, and therefore on top of the expressed breast milk, he received some infant formula. After those 10 days following the bronchiolitis, the NG tube was removed, but mom said after being discharged at home, feeding did not go as well. So he was healthy, but it just was not the same, and she started seeing weight dropping down after that. So you can see from the growth chart up to 4 months of age, you have your admission with bronchiolitis. So the bronchiolitis was resolved and then the weight started dropping. So the parents were advised to start solid foods after 4 months of age because this would help with weight gain. I put a little star there because I want to talk about this in more details. Solid foods was started, but he sealed his mouth and does not want to eat. He cries whenever the food was presented. And the parents were saying to me, they gave fruit, they give vegetables, they give different porridges, but he just doesn't want to eat any of that. Feeding time during a day was taking 5 to 6 hours per day, and I'm sure you have many examples of that. Mom tried to breastfeed more because she was seeing how the weight was coming down, and also then started to feed him with standard infant formula whenever he was asleep. She was so stressed out, so we call it dream feeding. So again, I'm sure you can identify with that as well. And she said to me, he will take 2 breastfeeds happily, and she said she gets 350 milliliters of formula whilst he's sleeping. So you can see dream feeding, force feeding, 5 to 6 hours of feeding. So I estimated, and I put the underlying on estimated because it's very difficult to estimate exactly how much a child is getting via breastfeeding. But I estimated that this child was getting 65 kilocalories per kilogram. Now, I wanted to talk about this advising solid foods early because this would help with catch-up. So first of all, you have to think, we know that WHO recommends 6 months, whilst there's no contraindication to say between 4 and 6 months. The question here for catch-up, does fruit and vegetables and porridges really help with catch-up growth? So, and I put here a note that when you are suggesting solid foods to help with catch-up growth, we know that the energy density of fruit and vegetables, which a lot of times is per 100 milliliters, 60 or 70 kilocalories per 100 milliliters, where breast milk is 70 kilocalories per kilogram, and also formula is 67 to 68 kilocalories per kilogram, and has protein and vitamins as well. So a lot of time when you start with solids, your fruit and vegetables will not provide you with the energy density. So think about it. Is the child ready from an oral motor skill perspective? Are we going to win calorie-wise when we're going to suggest early introduction of solids? Is it safe? And when I talk about is it safe, is it from a hygiene perspective? Because of course the WHO guidelines talk really about the prevention of diarrhea, gastrointestinal diseases by breastfeeding until the age of 1, or making sure that the food that is offered is hygienic. So that is what every clinician needs to take into account. Now, identifying feeding difficulties is very important. In this case, I think all of you can say this child has got a feeding difficulty. This is a very nice paper that was published already, now in 2015 by Bernie Kersner, but it gives you the features of feeding difficulties for those signs that you are worried about: prolonged meal times, food refusals, disruptive and stressful meal times, nocturnal eating. So we're talking nocturnal, that's nighttime, so that's dream feeding, with this child is having destruction, prolonged breast and bottle feeding. So I think with this baby we can tick almost everything, but you want to be thinking about your red flags, and that this child, there isn't a red flag, this child has got poor growth or faltering growth. I do also want to mention this publication by Natalie Rommel, and the message really is that below the age of 2 months, many of the children, whilst it's non-illness driven, there was an organic cause for it. So in this case, bronchiolitis, child was admitted, and then after that, although this is resolved, after that it led to a traumatic event, so nasogastric tube feeding, and this led to feeding. So behavioral feeding difficulties, so that is really shown here with a diamond, only kind of increases by 1 to 2 years of life. Before that, you often find there was some kind of cause for it. So before you say this is a behavioral feeding difficulty, think about what the cause is. It's really after the age of 1 that you start seeing that behavior only starts going up. So what is your feeding cycle? You often have here feed and food refusal for whatever reason. This then leads to weight loss and worsening of feeding difficulties. This then often leads to stress with parents, and parents often feel dismissed by healthcare professionals, and this in turn leads to the worsening of feeding difficulties. So for this, in order to be stopped, you need to be at every stage. You need to address the feeding difficulties, you need to address the weight loss, you need to address the psychological impact, and you need to provide tips for the parents of how to stop this cycle. So first, of course, port of call is we need to get this child to grow, because if this child grows, the stress will reduce. All of us know the WHO guidelines. Golden has also published complementary guidelines. These guidelines, just to give you background, are aimed to achieve 70% of lean muscle mass, 30% of fat mass. That's your ideal catch-up. So we don't want to just put a child on a scale and say, oh, this is fantastic, the child is gaining weight. We want to know that the weight that this child is gaining is not just fat. And therefore, the WHO FIO has come up with the guidelines to say, when you are looking at catch-up, you want an ideal protein and energy ratio so that you can lead to a lean muscle mass and fat mass that is ideal. I've highlighted here that for most of us, we don't look at 1 gram or 2 gram per kilogram per day of catch-up. We're looking at 5 to 10 grams per kilogram per day as catch-up. 20 grams I have never achieved in a non-preterm infant. So this is for full-term infants. So I always say, look at between 5 and 10 grams per kilogram of catch-up. That's more reasonable. But also I want to say that we need to ensure that nutritional aim is practical and is safe. And in this case, you have to remember this child is having 65 kilocalories per kilogram. So it is unachievable to start saying, I'm going to try for 125 kilocalories per kilogram. So it is more achievable to say, let's first look at 105. For example, that's 5 grams per kilogram per day, and see how this child catches up in weight gain. So, as I already mentioned, there's a strong relationship between energy and protein for catch-up growth. We want to aim for 70% of lean mass in terms of catch-up, and here it's really nicely illustrated. So if we're looking at lean mass, so that's 0.7, 70%, and you're looking at around 110, 120, we're looking at 5 grams per kilogram per day. The efficiency of catch-up, so the type of catch-up is linked to your protein, and the evidence is that between 8.9 and 11.5% of energy as protein is proven to be linked to this ideal catch-up. Now, there is some data to talk about stunting, so height catch-up may need more in terms of protein, but I think that is now being looked at further, because I think it's not only the percentage of protein, it's what type of protein. So the quality of proteins, the better the quality of protein, the lower the protein energy ratio. And I think that's also important. In addition, we need to not only think about calories and protein, which is a type 2 nutrient, we need to think about the vitamins and the minerals. I think this is a quote that I love from Michael Golden, so saying that it would be inappropriate to give only the type 2 nutrients, so only energy, fat, amino acids, and water. We also need to be thinking about these nutrients, and we also need to be thinking to the micronutrients we need to correct. So remember, I spoke about iron, zinc, iodine. If you've got a child that's got sodium losses, chloride losses, whether that's through a stoma, whether that's through diarrhea, that's an enteropathy, that needs to be resolved first. We need to figure out what the underlying medical diagnosis is, because I can give up to 150 kilocalories per kilogram. If you're losing sodium, then you will not be able to have the metabolic capacity to use the nutrients optimally. So that's also really, really important. If I provide you with a how-to guide for nutritional action, all children at some point have a little bit of a dip, whether that's a bit of gastro or vomiting or cough or cold, and they have a little bit of a dip to grow. So you can have they've not dropped 2 centiles, so monitor them and make sure that the parents are reassured. The second group is a group where they're flattening, so they've not crossed 2 centiles, so they've not quite at a faltering growth. But those you already want to say, I'm not going to wait for you to drop. I'm going to think, do I need to support breastfeeding? Is there an option here just for a short period already to get this child up to the right centile for with energy dense feed? Do I need to think about solid foods and how to adjust the solid foods? And then of course your last category is those critical categories where they've dropped more than 2 centiles or more than 1 standard deviation. And those you want to really jump on supporting breastfeeding, but also think about an energy dense feed at that stage. And I think we would all agree with this child has dropped 2 centiles, has got faltering growth. You really want to do something now. So what dietary advice did I give in this child? So of course, number 1, we motivate ongoing breastfeeding, and get your breastfeeding advisors here to ensure that the breastfeeding technique is optimal. Remember, in this case, the mother was saying, I was trying breastfeeding all the time. So you want to provide her with a routine, because providing breastfeeding with all the time also possibly means that this child only gets some sips of the foremilk and not the rich hind milk. There's not an optimal routine there. It might be that expressing some breast milk may help to top up. But then on top of this, this child was having a standard formula. So what I've said to the mother is, let's change to an energy dense infant formula. Apologies. And remember, this child was having 350 milliliters of standard infant formula. So just by changing this over, we already moved to 350 kilocalories, because there's a 1 kilocalorie per meal feed. We're giving 9.1 grams of protein. So that already per kilogram, because remember, this child was having 65 kilocalories per kilogram. That alone, the change, brings us up to 70 kilocalories per kilogram. Then on top of that, I provided help on how to reassure this mother, reduce the stress, bring the meal times down to 30 minutes. And most importantly, we've got some tips on solid foods here, but outside of reducing the stress, it's also how do we increase the energy density, sorry about that, for solid foods. Then we also suggested vitamins and mineral drops. Right, if we move on to some practical advice for what I suggested for solid foods, and in every country that would be different. So you need to think about what are the foods that you normally have within your Egyptian environment that contain both energy, so fat, carbohydrates and protein as well. So that might be olive oil, sunflower oil. I always give parents a guidance. It might be full cream yogurts. How much would that be? It might be adding cream to the yogurts. It might be adding cream to foods. It might be adding some extra egg to foods, or for example, cheese, some cream cheeses if you've got that, and then increasing the protein energy ratio. And I want to just bring this down to, if you're adding oil, for example, remember you need to add your protein too. So it's not just your energy, it's your protein as well. And we often add also seed nut butters or nut butters, and I put a star there that of course, unless you've got a peanut allergy or a nut allergy, we would not avoid any of the nuts. We would start them at least from 6 months of age actively. So in this chart, the mother found breastfeeding too stressful. She switched to formula only, and this child then had 550 milliliters per day of energy dense formula without any force feeding. You could see that we've had initial catch-up weight gain, so you can see it was 4 to 5 grams per kilogram per day, and it took some time for feeding practice to improve. So this was 1 month. And then as feeding practice improved, as the stress improved, the velocity, as you can see, increased here to around 7 to 8 grams per kilogram per day. And you'll often find that initially your catch-up can be slow, especially if there are feeding difficulties. Now, this is where we change to an energy-dense formula. And what is also important is here, we started here before the child was back on the 50th centile to already start changing to a standard infant formula. Let me explain to you why. What we don't want is to then continue on an energy-dense formula, and this child goes above the 50th centile where they were before, and you actually start having a child that is overweight for their height or for their length. Because of course, as I already highlighted before, excessive catch-up can also lead to a predisposition for obesity, cardiovascular disease in later life. The Early Nutrition Project has got lots of information on that. That's led by Bertolt Koletsko and of course also Olivier Goulet from France. So monitoring catch-up is really absolutely critical. So you need to think, when you've got your child, how badly is this child growth faltering, and then decide how frequently you're going to see the child. This is a really nice chart. Also, it's published by Golden, where you kind of go, okay, this is where the child lies. For example, this child was between -2 to -3 standard deviations. I was around the 3 to 5 grams per kilogram per day of catch-up. So it will take 20 to 30 days for you to start to see the catch-up on the chart. So I would see this child in a month's time. So it is all very important that you do monitor growth, and that you really do not let this child become overweight as a result of providing excessive amount of nutritional support. Then, of course, with catch-up, it's extremely important to measure them appropriately. There's also a chart that's from 1999, but it's still very valid to say, okay, what is the minimum interval of measurements? Because whilst you see that in weight, you do not see height or length catch up that fast. So this is a chart to kind of say, okay, for example, a 1.5-year-old, it's not worth measuring the length before 1.5 months, for example. And then on top of that, of course, you need to measure the growth, the length correctly using the WHO technique of a supine meter, not just a tape measure, not a roller meter, because you cannot establish catch-up growth unless it's done in the right way. We've worked together with Nutrition and have produced also during a pandemic how to do this at home measurement. I've been practicing and doing home consultations, video consultations for the last 20 months, and I can tell you it's worked really well. To educate the parents, we've produced videos of how to do it at home, and in some cases I've actually found better and more accurate measurements by parents doing it at home on a flat floor against a wall with two parents. So this is also really useful. So you need to be thinking about the lessons to be learned. There are triggers for feeding difficulties. You can divide them into size, transition, organic disease, mechanistic feeding, and post-traumatic event. In this case, the weight dropping led to compensatory feeding. In this case, possibly there was a problem that it was too early with too much force of giving solid food, so the transitioning from the breast and bottle to solid was most probably too fast, too forceful. And then there was the traumatic event of having the bronchiolitis and a nasogastric tube. So those can be triggered to lead to feeding difficulties as well. So what did we learn from this case? It's important to reduce triggers for stress and anxiety in non-illness driven feeding difficulties. Anxiety leads to wanting to feed more. Energy dense formulas allows to achieve target nutritional requirements with better energy protein ratios, and often it helps support breastfeeding because it takes the pressure off parents. It's important to also provide advice on solid foods and increase the energy density. Monitor the child's weight gain and velocity of growth. Advise also in a timely way when to switch from a fortification of an energy dense feed to a standard feed, and support this transitioning. So let's, for the last 5 minutes, move to an illness-related faltering growth. This is a baby boy born at 37 weeks gestation via planned C-section. He's got the diagnosis of a tetralogy of Fallot, so TOF and open heart surgery at 3 days of age, and he had persisted with a large VSD and overriding aorta. Further surgery was planned at 8 months, but as you know, to do that surgery, the child needs to achieve specific weight gain. So initially an NG tube was given, and this child was bottle fed with breast milk only, which he tolerated. And mom found it very stressful to continue to express breast milk and to provide nasogastric top-ups of standard infant formula. So this child was at the end just switched onto a nasogastric feed, but we did motivate the mother to try to continue some breastfeeding just for, comfort. So they found that as the child's requirements needed to go up, it was too much for the volume of just a standard infant formula. As you know, with cardiovascular diseases, you do not want to give too much volume as well. So there was this concern, the child needed to grow, you've got less volume than normal, and a standard infant formula did not provide sufficient energy density. This is a wonderful graph that Louise Marino has provided in terms of the congenital heart disease to think, what do you need to be thinking about? You need to be thinking about pre-operatively a long time beforehand. You need to be thinking about how are you going to get this child to have the right growth before they actually have their surgery. Then you need to be thinking about just peri-operatively and work towards reducing PICU length of stay, and then thinking about after the surgery, how do you avoid further sequelae as a result of the surgery? Now, in this chart, you can see weight started faltering. I've drawn the line, so this child was only born on the 25th centile, but if you look at the birth weight and you looked at where they dropped to, and I've converted that to Z-scores, it's gone to minus 2.3 Z-score, and you've got a faltering growth here. In fact, if you look at the Z-score here, it's also this child is malnourished. This child was managing maximum 400 milliliters per kilogram, so 90 milliliters per kilogram from the formula in addition to breast milk. Mom was spending more time and they were getting more and more anxious. At that stage, healthcare professionals suggested the concentration of the feed. So they suggested, let's add to the standard infant formula an extra scoop. So in 100 milliliters of water, add 4 scoops of infant formula. But the weight gain velocity did not increase in this child. In fact, the child started vomiting more as a result of this intervention. Then the healthcare professionals suggested give more fat and more carbohydrates in a powder, add this to the feed, but this also did not lead to any catch-up growth. Now let's just remind ourselves, this is an illness-related faltering growth. This child has got cardiovascular disease, and this child has got increased losses now with more vomiting, increased energy expenditure. As you know, with cardiovascular disease, we see that, possibly altered nutrient utilization as well, and that is leading to this poor growth. So what did we do? We first of all advised mom to say, we took some pressure off, saying, support breastfeeding, whatever you can do, don't stress about it. We switched to an energy-dense formula, and in this case advised a slow switch because there was vomiting. We just wanted to make sure that this child was tolerating it well. And then after 1 week, this child was totally switched over, 400 milliliters of energy-dense feeds, so now doing 80 kilocalories per kilogram, 10.4 grams of protein, so now 2 grams per kilogram of protein, and start on vitamin and mineral supplements. And we gave also advice on solid foods and the energy density of solid foods. What you can see is, although this child was not achieving the WHO 105, 125 kilocalories, you can start seeing that this child was starting, this is where we started, to catch up in a slow way with the same volume of feed they were having, was more comfortable, the anxiety improved, and we also managed to get some solid food into the child. This data is supported by the many publications, in particular recruiting children with post-cardiac disease, with weight improvement post-surgery. Here you can see it's not the first during PICU stay, but post starting, and you can see really nice catch-up growth and also good tolerance of the energy-dense feeds. So what is the lesson here to be learned with this case? The energy-protein ratio is disturbed if you start adding just carbohydrates and fat. So it can go down as low as 6%. And so we know optimal catch-up does not grow. In addition, if you increase the concentration, so by adding extra scoops of feed powder, you increase the renal solute load, so you increase the risk of dehydration. You can increase, as a result of that, the osmolality, which can lead to diarrhea and vomiting. In this case, it led to vomiting because it leads to delayed gastric emptying. And then, of course, it can affect the taste, it can affect the accuracy as well. This is a study, so these are hydrolyzed and amino acid feeds, but just wanted to show you, if you added an extra scoop of formula, you would go well above 400 milliosmoles, which of course is then hyperosmol. So what is the conclusion? Faltering growth should be managed using an individualized approach. We do have guidelines that have been published, but you need to think with that individual, is this achievable? And can you do it with that child? What is the underlying diagnosis? And would that work? Think not only about now, but about the future with your nutritional advice. So avoid excessive weight gain, therefore you need to monitor and ensure that the feeding advice also avoids feeding difficulties in later life. The modulation of feeds can impact on the characteristics of protein energy ratio, so we really dissuade people for adding extra scoops of feeds and modulating with just fat and or carbohydrates. Think about your type 1 and type 2 nutrients, so vitamins and minerals, and ideally, of course, you want to get your multidisciplinary team to be involved. Thank you very much for listening, and I'm looking forward now to your questions.